stated grouping.
What was that grouping?
Okay.
Nope, that's one of them. What was it called? What were the groupings called based on the glycoproteins on the surface of them? And they use them in, they still use them, like I said, you'll hear them called group A.
Oh, Lansfield.
Landfill grouping, still need to know that name, guys. They don't use it as much as they used to. Like I said, you guys will still see in your clinics and stuff, they'll say group A streptococcal infection or group A strep infection. Still use that one.
What was the name? Lansing?
Lansfield.
Lansfield.
Which organism causes dental caries that we talked about?
This is what?
What group, not the individual, what group causes dental caries? Has the organism that causes dental caries?
The alpha hemolytic streptococcus.
What's the name of the group? So you have group A, group B, huh? Viridans, that's what I'm looking for. All right, we discussed listeria?
Yeah, and we just started the pictures.
Yeah, we're about to start looking at the grandma.
The grandma can take. The money of the grandma? All right. So, what's unique about listeria again?
What do we think about it? Or
What's unique about it?
oh, unique.
Oh, the attacks and hides like within the cells, right?
Gets within the cells, actually gets within the macrophage. It gets phagocytosis. And because of this, Listeria lysin O, you don't get binding of the lysosome to the phagosome until you just don't get that for the bacteria, right? What happened here, people?
Everybody's starting Thanksgiving early.
Apparently.
Is there a sign-in sheet today?
Yes, there is.
Awesome.
Why?
Do we get extra credit?
Huh?
Do we get extra credit for being here?
Not a bad idea. All right. What part of the immune system do we talk about that gets damaged, not damaged, gets,
The active immune response, right?
which one?
Active immune
The
response.
part of which part in particular do you start having trouble with as you get older?
Oh, your
Your,
thymus.
yeah, your T cells.
Thymus, but what part of the immune system?
Your T cells.
The T cells, yeah, because they mature in the thymus. All right, so let's go through the step like this. Here's grandma, she goes and she has.
Cantaloupe.
Looks like she's drinking something.
Cantaloupe juice.
Cantaloupe juice, fresh cantaloupe juice. All right. Listeria triggers its own phagocytosis, so it actually wants to get phagocytosis. Okay? By the host cells, typically the gallbladder. The intracellular bacterium escapes the phagosome because it doesn't fuse with the lysosome, so it doesn't get broken down, right? Okay. The bacteria reproduces within a phagocyte. Some of the messenger RNA in the Listeria cell activate at 37 degrees centigrade, so the bacterium reproduces more rapidly inside of human cells. Man, it's a Monday. What does that mean? What does that evolutionarily? What does that tell you right there? That it's evolved over time to be pathogenic to humans. It gets in there at 37 degrees, it kicks in its genes and start reproducing more rapidly. The bacteria polymerizes the host cell's actin filaments into a tail. So what do actin filaments do inside of cells?
Don't they like project the?
Don't they grab on?
Oh my god. Oh no no. I got it wrong.
Anybody?
Don't they grab on? Aren't they for grappling?
Nope.
Aren't they good for like junction between cells?
Nope.
Ah.
But they're part of the cytoskeleton. So they're involved in that, but not more indirectly. Things actually anchor to them more, right?
So it attaches right to the cell and uses that as a cover.
Attached to other cells? That one?
Well,
They oh my gosh. The action, the like electrical like currents kind of like go through the.
They're pretty much basically involved, they're part of the cytoskeleton in general, right? So they're part of structure, but they also help the cell change shape.
Change shape.
Yeah, so they polymerize, they can push out on one side. So if you got a macrophage, how does it crawl around? How does it change its shape? the actin filaments, polymerized and depolymerized, polymerized and depolymerized. So what they're talking about here is this bacterium actually takes over some of the actin and has it start polymerizing, so it's gonna push out this little tail thing. Okay, so right there. So as it's polymerizing, it's pushing out the cell membrane, but what's right in here in this pseudopod?
Okay.
The Listeria bacteria, right? So it's going on here, moving out in the pseudopod. And it's gonna do what now? Because membranes will do what with other membranes? They'll fuse, right? So now it's going to fuse with the new host cell. It's going to bring it in. Is your phagosome? Is it going to get killed inside that phagosome? No. It's going to release and it's going to start growing again. And again, now it's going from macrophage to macrophage to macrophage without ever what?
Dying.
Dying, not just dying, but without ever what?
No, that ain't gonna do anything, right?
Not having to do anything, but it's not exposing itself to the immune system, is it? It doesn't need that capsule to hide from the immune system, it's just getting inside of the cells. Now, some of them are gonna be on the outside, but a lot of them are gonna be inside. It's moving from cell to cell to cell to cell. Pretty sneaky, yeah, I mean. And I said, that's why the T cell repertoire starts to drop off. No matter what, you're gonna get what on the surface of that cell. For the immune system, guys. What happens to intracellular
You're gonna get those
MHC class
Those-
1 molecules are gonna be popped up there, right?
Yeah.
So no matter what, you're gonna get those on there, no matter. But it's still doing a better job. It's not getting phagocytosed and destroyed. So T cells, your T cell repertoire, if you have a good, strong, hearty T cell response, are you probably gonna get that sick from Listeria? That's what I'm going for right here.
Oh.
Probably not. That's why,
Even if they go through apoptosis, you just release more Listeria into the body, right?
yeah, it would just break apart and, yeah, it's not gonna compartmentalize the Listeria exactly. All right, so there's an actual micrograph of it. I've got a whole bunch of this if you all want to have it. You want to have it? The Listeria cycle repeats as the bacterium reproduces within the new host cell. So that's a bunch of this over and over and over again. And now, what's wrong with grandma now? Grandma has a poor T cell response. The Listeria gets systemic. After things sometimes in the cells, Listeria can travel via the bloodstream to the brain where it causes meningitis.
Oh.
That's the problem with it. It can cause meningitis and it can kill very quickly. Because again, what are the symptoms of meningitis?
Flu.
Flu-like symptoms at first, and then what's the sort of significant?
Stiff neck.
Searing headache, usually in the back of the neck, right back here. That's usually a good one right there. But a lot of times it's too late. We're going to talk about these again and again and again. Did we go? We haven't gone over Syria yet, have we? All right. Diagnosis: you the presence of the bacteria in the cerebrospinal fluid if you have meningitis. But by the time they've done that, they better have you on ampicillin by now. Ampicillin works pretty well for most of them. Other antibiotics used for patients allergic to it, but they put you on massive IV dose of ampicillin because by the time you're in the hospital, it's really pretty critical at that point. At-risk individuals should avoid certain foods. What are the foods we talked about?
Melon. Oh no, that's
We got
botulism.
cantaloupe.
An ice cream.
We got ice cream. I just had ice
Just
cream.
like
Country charm.
gooey, watery ice cream.
Bluebell ice cream.
Bluebell.
How did that happen? Where do you think it came from, the ice cream of Bluebell?
Maybe there was like a layer on top where you scoop it, kind of like.
Where do you think it originally came from? What
Milk?
part about the milk usually where it comes from? So if that's the case, what else should you avoid? If you were in
Dairy.
high-risk food?
Anything dairy.
Dairy
Huh?
products.
Only dairy products that are not what?
Pasteurized.
Pasteurized. They did pasteurize your fine.
Why would they not pasteurize the milk and ice cream?
Well, that was later on. That probably.
Oh.
that was probably snuck through later on. In general, if it's pasteurized, you're usually okay.
Okay.
The problem is this stuff is ubiquitous everywhere, right? You find it in delis, you find it in all kinds of places. Somehow we just got in the milk there. But when you're looking, and it's just soft cheeses too. The hard cheeses tend to kill most bacteria and stuff, and they're pretty safe. It's things. So what are soft cheeses?
Brie.
Cheddar.
Bries are a big one. That's why they had that big. It was one of the Mennonites, I think, of Wisconsin. They had a big outbreak in their brie. So So be careful with the midnight regime. What else?
Mozzarella.
Some of those soft mozzarella, yeah, that can probably be one of them. With the blue cheeses, the Canberras, things like that. Also, what do they make a lot in Mexico?
Monster cheese.
Well, mustard, make a lot of mustard. Mustard probably, it's kind of no. But what are the ones they sell? The asadero?
Queso fresco, they have
The
like.
queso
Oh,
fresco, the asadero, all
that's
those ones, you
good.
have to be careful with those, because a lot of those are made with what?
No.
Non-pasteurized milk, so you gotta be careful with those. If you're in the high-risk group.
Oh.
All right, mycoplasma. Black cytochromes, enzymes of the Krebs cycle, and cell walls. I don't know how it lives. This probably means it's adapted to do what?
To do like a lytics or something, or like,
To do what?
oh wait, no,
Well, think most have sterols in the cytoplasmic membranes. So sterols are like cholesterol, right? They make your membranes more rigid. So these don't have cell walls, but their cytoplasmic membranes are a little bit tougher. So it protects them from osmotic forces a little bit more. Require various growth factors from the host or supply in the media because they don't have what? They don't have cytochromes, they can't go through electron transport chain. They don't have enzymes for the Krebs cycle, they can't go through the Krebs cycle on their own. Okay? Can colonize the mucous membranes of the respiratory and urinary tracts associated with pneumonia and urinary tract infection, and a few species cause significant disease in humans. We're going to talk about one disease in here. All right. So what shape are these going to be? How would they gram stain?
Are these negative or positive? They don't have a.
I don't know.
So it's positive, so they stain
What do you think? How are they going to gram stain?
pink, purplish, pink.
Green?
they're purple or like blue.
I don't know.
They're
What do you
negative.
think?
Are we negative already?
No, I'm positive.
So they're positive, so they're pink.
No, they're blue.
Blue.
Purple. And then the.
A, I'm
negative
worried
is-
y'all don't know the gram stain right now. B, what do you stain when you stain with the gram stain? What are you staining?
The membrane,
Cell wall. What are these things lacking?
cell wall.
Are they going to gram stain? In
No.
fact, if you put that acid, the decolorizer on there, you're probably going to do what to the membrane? Destroy the membrane. And that's that fried egg thing they look like. All right. The one I want you to know is this one right here. So attached to epithelial cell lining the human respiratory tract. Removal of mucus is impaired, which means what? Those cilia move the mucus up your respiratory tract, right? And you're supposed to swallow. These get in there and they just inhibit that movement, so you can't swallow that mucus, so it gets a buildup inside of your respiratory tract. This one I want you guys to know. Causes primary atypical pneumonia. So it's not pneumonia, it's not Klebsiella. Early symptoms are not typical of other types of pneumonia. What are the early symptoms of pneumonia?
Fever.
Fever, right? That's one of the fatigue, things like this. Doesn't have that, especially not the fever. Not usually severe enough. Short, long, short week. Not usually severe enough to require hospitalization. Most people with pneumonia, you're where? In the hospital, right? This is that walking pneumonia. Have you ever heard of that?
Oh, my brother gets that all the
I
time.
had it once before, and it just makes you miserable enough that you are miserable. But not enough to not do anything else. That's the problem with it. So know that one. The one mycoplasma pneumoniae, okay, it should be pretty simple. If I say, what does mycoplasma pneumoniae cause?
Walking pneumonia.
Walking pneumonia. Just remember, it's not regular pneumonia. It's going to be atypical pneumonia. Why does it look like this? So this question is very big.
Why does it look like that?
These are what they look like. They're called pleomorphs. Pleomorphic. They don't have a designated shape.
Because the
Why?
cell wall doesn't hold their
So they
shape,
can merge
right?
together.
No, cell wall. What gives the bacteria shape? Cell wall. So what antibodies would I use on this?
Something that attacks maybe like the protein synthesis or like cell.
Use one of the ones that goes after, probably one of the ones broad spectrum that goes after protein synthesis, right? Can't use any of the beta lactanes because why?
Cell wall.
There's no cell wall.
No cell wall. How about vancomycin?
That's just like,
Yeah, doxycycline, tetracycline would work, erythromycin would work. Anything goes after protein synthesis. Alright, treatment, macrolides, doxycycline, fluoroquinone, just, if I have on that test, if you prescribe a patient with walking pneumonia, if you prescribe a patient with walking pneumonia penicillin, is this the correct course of treatment?
Well, this penicillin is botched.
Yeah,
Yes.
I don't know, think about it, a couple of the antibiotics I want you guys to start becoming familiar with, how they work. Tetracycline, the ones I asked you about, tetracycline, erythromycin, sulfa drugs. How does penicillin work?
Beta-lactam,
The
Beta-lactam.
beta-lactam, which means it damages what?
cell wall.
Growing cell wall. These have cell walls. So would you prescribe penicillin?
No.
That's kind of a tricky question. Don't get. All right, patients often infectious without signs or symptoms. This is one of those ones where you can be a carrier for this. Some people have it, they never really show that they're ill, but they still have it. Proteobacterium. This is another pleomorph, which means it has no cell wall, right? Non-indisposable bacteria. What does ubiquitous mean again?
Liquid.
Huh?
They're in like liquids. or something?
They what?
They're like in liquids. Or
Nope. Nope. Ubiquitous means what?
Yeah.
Well, they could be liquids too, yeah.
It can get on plants and animals. It's like
Everywhere. Ubiquitous, kind of, ubiquitous means everywhere. Two different terms you hear in old school, you may hear when you get into clinics from old school people, ubiquitous and cosmopolitan. Have you ever heard of that term? Not the magazine on the shelf that says the best blank you've ever had in your life, do this, whatever. That's Cosmo, that's a different thing. Cosmopolitan also means it's going to be worldwide and ubiquitous around, especially people. You hear a lot of that with parasites.
parasite.
All right, don't worry about the staph invasion, we're not going to worry about that. From liquid, it's colonized the skin, respiratory, gastrointestinal, urinary, and genital tracts. Again, this stuff is everywhere. This is the one I want you guys to know because it's important. Corynebacterium diphtheriae causes diphtheria. That's the only one for. This used to be a huge problem, guys. Still endemic in poor parts of the world has been lacking immunization, transmitted from person to person. But the weird thing about it is the diphtheria toxin inhibits polypeptide synthesis in eukaryotes. That's us, right? And the bacteria that do not produce the toxin are apathogenic or non-pathogenic. But how does this kill? Anybody ever know? Everybody knows they get the DTaP, right? The diphtheria, right?
Mm-hmm.
You might even know what it does. It used to, well not used to, it still will form a pseudomembrane across the throat. And you'll just eventually do what? Suffocate, it will block off the entire throat, cause suffocation.
It causes it by swelling? What are we talking
No,
about?
it actually starts producing a pseudomembrane. So it's not really a membrane, right? It's a pseudomembrane, it's a covering of it.
Oh,
So right here, this starts to grow right here, like this. And eventually it'll start moving over here, and eventually it's gonna cover what? The entire throat. Now what are you gonna do? Can't breathe, what do you think the next, only other option before antibiotics?
Be-
Which one?
intubate.
Oh, it's right?
Yeah,
but
intubation.
that would be kind of, could do that. What else?
Remove your tonsils.
Nope.
Remove
It's
the
surgical. They have
membrane?
to go and surgically remove the whole thing.
Yeah.
And the problem is, what happens when you start taking those things out a lot? Especially in old days.
Old
Could
bleeding.
be a lot of bleeding. Could be a bleeder right there. So that was one possible thing like that. So diagnosis is the presence of the pseudomembrane. Don't worry about the ELF test. Administer antitoxins to neutralize the effect of the toxin. Penicillin, erythromycin, you want to kill the bacteria too, right? But if you've got a blocked airway, if it's progressed to that point, surgery is going to be required to fix it.
Did I?
All right. We're almost there. Mycobacterium. This is what I said I would talk about this one later on. Mycobacterium cell wall contains mycolic acid, which is an oily, waxy lipid coating, which means you cannot gram stain these. Gram stain does not work. You have a piece of thing called acid-fast staining. They grow very slow. Protection from lysis after phagocytosis. Capacity for intracellular growth. This is another one that likes to get engulfed by macrophages and then start growing inside of them. Resist gram staining, detergents, antimicrobial drugs, so they can't get to that cell wall, and desiccation and drying out. Does anybody know what these two are we're going to look at? It's actually three.
What was your question?
Anybody know Mycobacterium falls into this one? TB is going to be the first one. Good. Mycobacterium tuberculosis. What does it say? We'll talk about consumption in a minute when we get to that. M. tuberculosis is not highly virulent. What does that mean?
You can't pass it. If you can, but it's very rare that you pass it to somebody.
So why is tuberculosis such a big deal? Did we talk about this before about TB? We talked about infection? About being, no? Why is it not really, why is it such a big deal? It's actually pretty hard to catch,
What?
surprisingly enough. Not very virulent, not super hard, not easy to catch. If it did, everybody who's ever been in an airplane back in the day would have TB by now. Because what happens in airplanes?
That's true.
Well, isn't it like you have to be careful where you are because it grows faster if it's like somewhere moist, right?
Right, so what if you were to drive around, all around the Southwest, you'd find old sanitariums, they call them tuberculosis sanitariums. There's a bunch outside of Ruidoso, outside of Phoenix and places, so they would move people out here because the dry, warm air seemed to help. It's not as infectious as people think. The problem is there aren't that many antibiotics to treat it.
Oh.
There used to be very few, and once you get it, what can happen? What's your long-term prognosis a lot of times? Not good, right? So it used to be the scourge, it was everywhere, but it's not as easy to catch as you think. Otherwise, every one of those babies in Providence would have what now?
Oh
Remember that?
yeah, the nurse.
There was a nurse at Providence in the pediatric unit who had what?
TB.
She had active TB.
How did those doctors that worked with her not catch?
The whole big thing. Did anybody hear about that? You all remember that?
Yeah.
Okay, you ready? What happened with it? Somebody I know in my other classes, they had a kid was actually in there.
Oh my gosh.
So what happened? What was the problem?
She was like coughing up her lung like the whole time.
But what was the biggest problem from a legal standpoint?
Yeah, the hospital and someone that's sick working.
Yeah, but apparently the hospital knew.
Oh.
How did they know
Yeah,
what?
they actually knew. So I don't know whatever happened to that. It went kind of hush hush. My assumption is, I don't know.
They're paying people and
Yeah,
they're
that's what I'm wondering because it's kind of disappeared. All right, so this is a colored stain that acid fast. Don't worry about that. You need to know the three types though. Primary tuberculosis is the initial infection. You get sick, start coughing up, pretty nasty. It can take a while. How long is typical antibiotic therapy for TB?
months.
Months.
And you have to go into the office to take it. Like, isn't that the one where?
There's some now, they want to make sure we comply.
Yeah, exactly.
But I think it starts at 6 weeks and goes up from there. 6 weeks to 6 months, some people are on it a year, depending on which one it is. There is MDR tuberculosis, which means what? What does MDR mean, guys?
MDR.
From a couple chapters ago. This is stuff you all need to know when you see this, because it's going to make a big difference in clinics. If you see some of the patients, they're probably going to be in isolation. You see MDR tuberculosis, that means what? It means multi-drug resistant TB. That's the problem. And the problem with TB is you only have a few drugs to begin with, so you start getting multi-drug resistance, your repertoire of drugs goes way down fast. There's also XDR TB, which is resistant, I think, 5 or 6 of the drugs out there. And that might be why they make you go to the office, because compliance is a huge problem. Has anybody here ever been on antibiotics for more than 2 weeks?
So it's 10 days.
I was on it for 6 months one time. And compliance is
Hard.
Yeah, it became part of my life. Wake up every 4 hours, not wake up every 4 hours, but every 4 hours.
That's crazy.
That's a big problem. If you're on it a year or more, who's gonna take it every time? Secondary reactivated tuberculosis, reestablishment of active infection after period dormancy. They like to get in your lungs, they get inside the macrophages, and you make these tuberculi, which are these little nodules that get in there. They're basically walled off macrophages with mycobacteria in them. That's what they're looking for in the chest x-rays.
All the
They're looking for
nodules.
people with TB. So if you go down and you get a positive TB test, what's the next step?
X-ray.
Chest x-ray, to see if you've got those in there.
So when you don't have the nodules, that's when they call it an inactive TB?
Nope, this can actually be inactive too, once it gets inside of there.
Okay.
Make sure they get in it, we'll go over that in just a second.
Sorry.
Okay? The third one is called disseminated tuberculosis, or this is the one they called consumption back in the day. So results when the infection spread through the body, symptoms arise due to complications at various sites involved. It just starts to consume you from the inside out, and that's what they used to call consumption. These old you see those patients are gaunt, thin, coughing up blood, just not very good shape, and eventually they're gonna what?
Dying.
They're gonna die. Okay. So, okay, let's go through this right here. So here's what happens with TB. You get the primary infection, the tuberculosis gets inside of the respiratory tract, you start hacking up all kinds of stuff. What's your immune response gonna be? For
Macrophages.
bacteria?
Macrophages.
Macrophages and neutrophils, in this case, a lot of macrophages in your lung. So macrophages, phagocytosis, mycobacterium, but are unable to digest them. They get inside of there again. Instead, the bacteria replicate freely within the macrophages, gradually killing the phagocytes. Bacteria released from the dead macrophages and are phagocytosed by what? More macrophages, right? So it's this ongoing little battle in your lungs. All right.
Wow.
So, the next thing that can happen is you get infected macrophages, present antigen to T lymphocytes, so now it's your adaptive immune response that kick in, which produce lymphokines that attract and activate more macrophages. So you're just trying to rev up your immune response, right?
Yeah.
So you trigger formation, tightly packed macrophages surround the site of infection, forming a tubercle over a 2 to 3 month period. So they start, you've got this massive battle going on. Eventually they're able to do what? What
Over.
does your immune system do if it can't kill things? What does it like to try and do?
Oh, like it, not calcify it, but it likes to surround it and
It
like.
likes to wall it off, we
Yeah.
call it. It likes to trap it and wall it off, and this is what happens.
Oh.
It gets inside of here, you got collagen fibers surrounding it, you got a bunch of macrophages in there that are infected, and then everything does what?
Dies.
So other cells deposit collagen fibers enclosing infected macrophages, and you get this big.
So is the collagen fibers are our response, right?
Yes.
Okay.
Because your other cells come in there and start releasing that. Because they're trying to say, you can't kill it, you can't get rid of it, the body likes to wall things off. That's what plants really like to do, because that's really the only thing plants can do, right? If you look at a disease in a plant, what are they trying to do with it? You ever seen what happens?
Yeah, they grow.
They grow, they just try and cover it, surround it, and try and sequester it in there. All right. So, where are we? Tuberculosis producing causes necrosis, the death of tissue that takes on a cheese-like consistency due to protein and fat release. That's just gross. You're going to hack it up.
God bless you.
Okay, but what happens? What's that last sentence?
Stalemate between the bacterium and the
You
body.
get a stalemate. Your immune system is strong enough and everything else, you sort of come to a, kind of like Korea, right? You got north and south, right? You got a stalemate going on.
So those nodules just stay in the alveoli,
You're there
and that's
for-
the problem.
Those are there forever.
Ever. Oh.
All right. So there's that nice cheese like yum, yum, yum. Lung lesions caused by TB. But
Uh-oh.
what can happen? We did what? So, Results when tuberculosis breaks the stalemate, so it actually ends up winning that little battle. If it can, overcome your immune system. These things rupture, and this is where you have secondary or reactivated.
Reactivated.
And that's what happened to that nurse. She had reactivated TB. So now, disseminated tuberculosis results when macrophages carry the pathogen via the bloodstream, because that's what macrophages like to do, right? And they go where? Lymph nodes, bone marrow, spleen, kidney, spinal cord, and brain. And this is where you start getting that disseminated, that sort of that consumption. You just start getting what from the inside out?
Eating it.
Dissolved almost from the inside out.
Wow.
Yeah. All right.
It goes to your brain, and I'm sorry.
It goes out, it disseminates everywhere. It gets in the bloodstream, and it can get through the blood-brain barrier, because it just goes everywhere. All right. Cases are declining in the United States, except what's happening now because of drug resistance? This is when they're going to throw in the re-emerging category in the U.S. and stuff. They're starting to come back up. And we're in particular trouble because why? Any international borders are always going to be more problematic with things like TB, right? Because you've got international travel coming across.
And then you got those parents that don't want to vaccinate.
Then you got that. Now, there is a vaccine kind of for this, but it's kind of iffy right now. So, because drugs were working pretty well for it, that's the problem. Most common in Asia and Africa. But look at this right here. I said it wasn't very virulent, but what does that say? 1/3 of the world's population is TB positive. Not super virulent, but it's everywhere and it gets around.
So why? Why if it's not?
Because it takes so long and you're around it for so much and you can't really get rid of it. Some people never get drug therapy for it. Some people it becomes inactivated and they're fine. It's just sort of back there all the time. You get people at close quarters. Multi-drug resistance and XDR resistant strains and then tuberculosis developed in some countries. That's going to be a big problem. That's what they're worried about. All right. Diagnosis is going to be the TB test on the skin. Who's ever had one of those? Anybody ever? Everybody should have.
I just did one, 2 of them.
We used to get it when I was in school. We had them every year.
Oh wow.
Chest X-ray individuals with active disease or they just have those tuberculosis. That's still, because it's still in there, right? It's just sequestered off. All right. What can cause a positive TB test? Because they're more common than people think.
Oh, you're not supposed to.
If you get the vaccine for it, it's going to trigger it to be positive.
Well, what is it? Because they always tell me, like, when I did it, they said, like, I'm not supposed to put, like, lotion or, like, scratch it or put soap on it.
Yeah, because they can get really irritated and stuff like that. You can probably get a staph infection. They're probably more worried about that than anything else. What else can cause it? There's a couple other mycobacteria that can cause it because it's really looking for the genus, not the species. In particular, there's one called Mycobacterium avium, which you get from what?
Birds?
Birds. And if you're a healthy individual, it doesn't do much, but it will trigger a positive TB test. Okay? We were working on it at UTEP one time, and one of the guys who was really cute on that project, he ended up testing positive for TB after that. He got exposed to it. No big, I mean, it's no big deal. But.
Well,
Combination therapy used to treat for months, sometimes up to a year, depending on how well it's working. And again, they've got that vaccine for it, but there's some question as to how well it really works. So there's the X-ray, there's the TB test. Oh, that's a pretty small one. Do they use the shot? Who's had a TB test in a while? Do they use the little shot, or they still use that little thing with all the prongs on it?
the prongs was the what I
I
got.
had a shot.
You had a shot?
I had the prongs.
You had the shot? Who else had it over here? Shot? Yeah, they're doing the shot now. That's probably what that is now. They just go in there, substitute under there and get in there. They used to have this thing that, I
Yeah.
don't know what, it was like a torture device. It had these little prongs all over it and it had TV on it. Did you ever have one of those?
I had that.
Really? Oh, you did? And then,
It would look like a pen, no? And then
yeah, cram it in your
yeah.
arm. God, that was miserable.
So those are the nodules. They don't. It looks. I would have thought it looked more like pneumonia than the.
Well, it's just gonna be an X-ray dance thing in there, right? And you pretty much have to know what you're looking for. Pneumonia is gonna be more what, fluid-like stuff in there, where you can see these profiles. And I'm certainly not a radiologist. but
That's true.
To me, I'm like, could be something. All right, the other one's Mycobacterium
Ugh.
leprae, also referred to as Hansen's disease or
Leprosy.
leprosy. That's an easy one. This is interesting though. It grows best in cold regions of the body, which means if you have leprosy, where is it going to grow first?
Your fingers,
Fingers, toes, where else?
and your face.
Your nose and your ears. So all your extremities start doing what? Disappearing. Okay? Bacteria cannot grow in self-reproduction. Gotta grow, gotta be inside, gotta have cells to grow. And right here, those cute little armadillos
Yeah.
that are running around, do not go and hug an armadillo for more than one reason. One, they might get leprosy. B, they're mean, ornery little critters that are gonna scratch and bite the heck out of them. Do they bite? Anybody ever been around them? I know they scratch because they're burrowers, they got big old claws.
I was watching Monsters Inside Me where a kid kicked a dead one, and he got that on his shoe, and somehow he got
What did he get though from it? You know?
leprosy.
Oh, he got leprosy?
Yeah. And passed it to his like family. I don't know. It was weird. I don't know.
Leave the armadillos alone. Leprosy, two different forms. You got the tuberculosis, which is non-aggressive form of the disease. But what do we say? It needs cell culture to grow. That means it likes to grow where inside of you? Again, it's an intracellular parasite, pathogen. So, if you have, and what part of your immune system goes after that?
T cell. T
Your
cell.
T cell, right? So, if you have a strong cell-mediated immune response, it's not gonna what? You're not gonna come down with leprosy really badly. Again, that's why back in the past, what they used to have all over the world.
Leper colonies.
Leper colonies. Did everybody who went to a leper colony get leprosy?
No.
No, it'd be pretty hard to get people to work there, right? Probably pretty hard to get people to work there anyway. But for years, they didn't know why some people got leprosy, others didn't, and it turns out it's your T cell response.
T cell response. I thought it's because you had to be exposed to like bodily fluids and.
It is, but people were working with these people.
They were still not getting it.
it. So they get exposed to it, but it turned out now it's happening to their cheese. A lot of these are looking at, a lot of these things like we talked about, necrotizing fasciitis, they're pretty sure it's what? Why doesn't everybody get necrotizing fasciitis?
T-cell response.
And then don't listen in class. What did I talk about? What do they think it probably is? Whatever I listen to, oh, spots up there. What is it? They think it's immune. They think it's differences in immune response. Some people
Well,
just
that's
don't.
what Sam said.
If red origin have a weak, not necessarily T-Rex response to that one.
Oh.
For necrotizing fasciitis, they just think it's different. It's probably neutrophils. This is the lepromatosis. Leprosy is the more virulent form of the disease, and it's going to be due to a what?
Weakening.
A poor T cell response, cell-mediated response. It gets inside there, gets a foothold. Becoming relatively rare. There are still a few places. I think India still has some leper colonies. I don't know where else.
Doesn't the United States have one like in Hawaii or something or?
I don't know because, well, it's kind of weird. So let me think about it. We might. I have to look.
My
I think
dad.
we would treat it like transmitted person-to-person via contact or break in the skin. That's what's here. What is different about leprosy versus gangrene or necrotizing fasciitis or a staph infection?
Does it work from the inside out?
But how does it work from the inside out? What do you mean by that?
Let me think.
What is different from the wounds on this person than you would see if they had, say, gangrene?
Oh, it's closed. The gangrene is oozing
So,
and.
like open wounds.
There are no open, sore, oozing wounds with
And
leprosy.
there's no like dead skin really, is there?
It grows so slow, it sort of kills back the tissue, but the tissue's still able to sort of heal over it. So you sort of,
Oh.
it's like getting an eraser kind of, sort of erasing part of the person. So you don't have these big oozing open wounds or anything like that. They're dry, they're just kind of weird the way it works. Based on signs and symptoms, your nose, your ears start falling off, you might want to get looked for leprosy, right?
There's no
Combination of
others?
antimicrobial drugs. The problem with leprosy that we talked about is what?
Lifelong.
Sometimes it's lifelong treatment, they have to be on it, stop it.
So the only symptoms your nose falling off? Like really?
Well, no, you start getting, I mean, your limbs.
Start losing feeling?
Well, so what's gonna happen in your limbs, do you think?
You start losing
You guys may be
feeling?
Clinicians, yeah, what do you think's gonna happen?
You're gonna start losing feeling?
You start losing sensation, you might get some tingling in there,
Is
you
it
start.
hot to the touch?
I don't even know if it's not to the touch, it's just more start getting these weird sensations like tingling and kinda in your extremities.
So you won't see the black, like the death of the tissue on
Well,
the
yeah, you would
tips?
eventually, yeah.
Oh, okay.
Yeah. yeah.
Okay.
Like your nose, whoop.
Yeah.
And just like wear gloves and try and keep your hands warm so they don't grow hair.
That's
Yeah,
true.
keep it hot water.
Yeah.
Slow it down. Might actually work. All right, this is the last one. Mycobacterium avium, intracellular, most common mycobacterium infection among HIV patients. Because HIV patients have lost their,
Immune response.
which part of it?
T cell.
Their T cell response. So these are all intracellular, right? So these people are going to be very susceptible to this. The infections result from ingestion of contaminated food or water. And again, this is one of those ones that normally isn't bad, but if you get it, what happens?
Organ failure.
Massive organ failure, more consumption, definitely in HIV patients. And again, treatment is difficult due to the disseminated nature of the infection. So think about it. You've got this already through your body, it grows really slow, so the antibiotics are going to take what? A long time to do their job, so this could just wreak havoc inside of these patients. I don't think I'm worried about this one. I just think I put this one in here in case anybody's worried. This is the one that causes what?
Acne.
Acne. But I think I just put this there more for your own. Unless you guys, you might gonna be a dermatologist here? Okay, we're not going like that. That's okay. That's why it's so hard to get dermatology residency. Why? You guys know?
No.
Why do you think it's hard?
It looks the same.
Huh?
Everything kind of looks the
Everything kind of looks the same, but
It's
what do you
gross.
spend your whole life doing?
Popping pimples.
Popping pimples, you know?
Yeah, I mean, someone got
Mostly
COVID.
teenagers coming in, they're worried about acne. Not a real tough gig. And they make pretty decent money.
There's some nasty stuff out there though. that
There are some that actually is pretty good.
Like they don't like treat it for years, so like when they pop it, it's
Oh.
like fountain.
Oh, I
Some
know. I'll
put it-
find one of the pictures they have that pus inside them where it squirts out like toothpaste.
Isn't there like
about an hour.
a movie? I'm not a movie, a show, TV show about that?
Yeah.
I got a question with the
Yes.
bacteria.
Yeah,
That one has no cell wall?
yeah.
It's for the crop
No
pimples.
cell
That's
wall.
so gross.
Yeah, you can buy the pest
Treatment is,
pill and you put it.
Let me see. So let me go back and double
Yeah, I
check.
did see it.
What did they
That's
say,
so-
treatment what?
Penicillin or erythromycin?
Let me double check. Let me back there, shouldn't have it.
Oh yeah, I did catch that. I thought that was weird.
Whoa.
You went too far back.
Oh, that was the macrophage or something. Pleomorphics. Where is treatment? Penicillin erythromycin kills the few cells of the bacterium. It must not have a very structured cell wall. It must have somewhat of a cell wall. But I actually, that's an assumption I made on my part. I always thought of going back there being pleomorph. Most pleomorphs don't have cell walls. So, but it must be. Let me look into this and I'll check next week for you guys. Maybe that some of them that have cell walls that are pleomorph just don't have a defined shape. They sort of morph into. So we double check. Thank you for catching that. All right, I'll bring.